in the prophylaxis right now, there is not a lot of improvement. In previous years, we have a lot of improvement with the development of the use of ATG, of anti-thymocyte globulin. That was a real improvement for the prophylaxis of GvHD, of chronic GvHD, but also of acute GvHD. In fact, despite the improvement, the incidence remains stable, mainly because we are using some new donors and some new strategy. Now we are using more and more unrelated donors or mismatched donors, and we are also using more and more peripheral blood stem cells instead of bone marrow, and all of that are well recognized as risk factor of graft-versus-host disease, and this is the reason why when we are going to focus on the overall rate of GvHD, the incidence remains the same. But when we look more in the details, we saw that with the use of ATG, the incidence of GvHD is lower when we are looking only of matched sibling donors or unrelated donors. So this is the first thing. The secondary important thing is the development of post-transplant cyclophosphamide that is used first in the haploidentical setting, but that is very, very interesting also outside of the haploidentical setting, that is starting to be used also for unrelated donors and also for matched sibling donors. So right now we are waiting for some results from some randomized clinical trial that are going to compare the use of ATG and the use of post-transplant cyclophosphamide, and we'll know maybe in 1 or 2 years what is the best. And maybe, and we don't know also, maybe the best thing will be also to combine some low doses of both of them, but still we need to have more data before we can conclude, and expect that in the next few years, the incidence of GvHD may decrease thanks to these improvements.